go way back in time. People are taking progesterone creams and estrogen creams, and nobody separated estrogen and progesterone because their responses are different. As you pick those apart, treat the hormones separately, and really interrogate those conclusions, you realize there's no substance to that. And the truth is more nuanced. I make the 2-hydroxy. I don't turn it very well into the 2-methoxy, which means for me, I could use support in that area. Magnesium, things to support methylation. Why? Well, because as a guy, those 4-hydroxyestrogens are also relevant as it relates to prostate cancer risk.
Hi, everyone. Welcome to this podcast episode. I'm going to be speaking with Mark Newman today, and I'm really excited for this podcast episode. Mark is a recognized expert and international speaker in the field of hormone testing. Mark spent nearly 25 years developing and directing 24-hour urine, organic acid, and salivary hormone testing labs. His unique experience led him to pursue a revolutionary way to test hormones, and Mark began his own lab, Precision Analytical, to create the most comprehensive functional hormone test available, which is the Dutch test, or dried urine test for comprehensive hormones. Mark is committed to making it easier for patients and their healthcare providers to answer complex clinical questions through extensive education on validated hormone research. Every day, he and his team of experts work towards their mission to profoundly change one life, and then a million more through industry-leading functional hormone testing and education. So, Mark, welcome to the show, and thank you so much for your time.
Yeah, thanks for having me. Looking forward to our conversation.
Yeah. So I want to start off by just mentioning a little bit about, so people understand my background on the physician side, which is that we barely get taught, as you know, true science or the whole science around hormones, up to date science in medical school and throughout residency training. And so a lot of times our knowledge around the subject is when we go out in practical life and meet patients and then see what's lacking, and then try to really relearn a lot of the things that we've learned through our training. And so, with that background, I want to understand just a little bit more about your background in creating the Dutch test, how you really got involved in the field of hormone testing, and maybe we could start from there.
Yeah, My angle into this world is from the analytical side. So I got a chemistry degree and started down the direction of forensic science because I really wanted to tackle problem solving from kind of a laboratory perspective, and just kind of fell into the world of hormone testing, which is from an analytical standpoint, testing a little white powder to see which drug it is, and testing a biological sample for a novel metabolite or something like that it's very similar in terms of what you're actually doing on a practical level. And so I got into assay development and just really loved, like, how do you build this mousetrap, and then how do we build it in a way that's easy to do and comprehensive, and really tells a story that adds information to just put a tool in the hands of a smart provider like you to just move in the right direction with better success when it comes to just trying to solve problems that patients have that may be related to hormones.
Yeah. And how was your journey through in terms of what you started with, and then how you came to the Dutch test? Do you mind telling a little bit about that?
Yeah, I mean, what we do is a little bit of an intellectual hybrid of the things that I've been exposed to, which is to hop from a 24-hour urine test where you've got these, there's a lot of stuff you can dig for that's related to hormones in a urine sample, but being in that world and seeing the difficulty that people had just with collection and compliance and that sort of thing was one issue. And then from a data standpoint, the other issue is, if I've got an inverted cortisol story where my cortisol's high at night and low in the morning instead of the opposite, which is appropriate, in a 24-hour urine sample, that data just disappears. And so going from there to a saliva model where now I have a better view on the diurnal pattern of cortisol, which is nice, but I've given up all the information that you can get from this other sample set. So from me just peering into saliva testing, blood testing, urine testing, and I kind of divide it into two worlds. There's one I always just call commodity testing, like
Mm.
blood testing, CBCs and blood chems and even
Right.
hormones in blood. It doesn't matter that much for the
Mm.
most part where you get it. It's all highly standardized. It's a
Yeah.
commodity for the
Right.
most part. And then you get into specialty testing. And
Mm.
in specialty testing, man, you can ask some really interesting, rich questions.
Yeah.
But then there becomes this quality validity question of needing to weed through all of the things that are available potentially and make sure that we're telling a story that has some substance and validity when it comes to actual evidence. And so our approach has been to complement all of that commodity lab testing, which
Mm.
is completely necessary. I mean, it's actually more important than what we do, right? You need
Right.
blood chems and all of those things. And
Mm.
then our job, I think, is to complement that by giving a deeper, rich, broad picture
Mm.
of, in our case, the hormone story, and to try to weed through the things that are just noise and create panels that really give meaningful information. So that's the test. And then
Yeah.
the challenge beyond that was, well, if this test is interesting, but it's outside the norm of, as you said, what you're educated about in medical school, then the
Yeah.
education on that side of things becomes then the sort of dual challenge to us is making the panel in a way that's useful and helpful, and then creating education that helps providers like you,
Yeah.
make those connections between numbers and things on the lab test to
Mm.
actual things that matter for your patients.
Yeah, and that's what I love about your company, how you have the testing part, but you have also a very comprehensive educational program to be able to combine those two together, and certainly benefited me quite a bit. I want to start by maybe taking a bird's eye approach a little bit, because I think us as clinicians, because we're so busy with the day to day,
Hmm.
patients and everything, we oftentimes don't get a chance to really dig our hands and feet into the research dirt, as we can say. And that ends up with people thinking that they know what the research says, in a more of a almost a dogmatic way, right? There's that study that will tell you that this is the way that you believe, and this is a clinical validity, and then you go that way, and you have these studies to basically validate your opinion, and then the other side has it as well. And I think hormones is definitely that area in medicine where there's just so much misinformation, confusion around, because of the history of the Women's Health Initiative, all the stuff that we've
Hmm.
had in terms of misinterpretation, um, opinions, all of those things, and that have bled into clinical practice. So I just want to take that moment to just appreciate how a clinician, even though he might be skilled in seeing patients, that doesn't mean they went back and dug into the data themselves. And so I really
Right.
appreciate and respect those people that can do that. Oftentimes in a journey myself to do that, so that when it comes to seeing patients, I'm not telling them, hey, this is what the literature says, and doing it in a secondhand way. I actually know the literature and can do that.
Right.
So yeah, I was just wondering if you could speak more broadly to literature as a whole, and perhaps
Yeah.
in your experience in for so many years around hormone testing, what you've seen in terms of this dogmatic approach and all of the misinformation out there.
Yeah, I mean, it can come across as, from your perspective, a compliment to me and an issue with someone else. But the truth of the matter is, I don't have the time and wherewithal
Right.
to dig into the literature for everything that you need to be competent about either. Right?
Yeah.
It's not. I mean, it takes a community, but this community that we're in needs to have high standards because you've got, you described a study that says this and a study
Mhm.
that says not this. But
Right.
it gets even more basic than that in that in my industry of functional medicine, there are very well respected people that just say things and take positions that
Yeah.
you can't defend from the literature, and it becomes, I mean, dogma is a really good word
Yeah.
that we need to try to avoid, and that can hit on treatment efficacy, right?
Mm.
Of risks of things. I mean, there are certain things in our field where the risks associated with them have been sort of exaggerated. The WHI is sort of an opposite story of where conventional medicine has gone way too far in ascribing, contributing risk to a particular type of treatment. That
Yeah.
as we step back from it and look at more data and all of that, the story is different. So dogma comes from sort of both sides, and so that's where we're really, dedicated to trying to go to these topics with open minds and open hands and say, okay, let's just wrap our arms around the literature as it relates to hormone treatment and then
Yeah.
also hormone monitoring. And they're complex topics, and they're ones that, we're just right now working on an HRT course. Like we've put out a
That's
lot of
excellent.
material that's a little bit hodgepodge here and there, and then we've put out hormone education.
Right.
But the HRT education is something that we're still working on. And as our experts have dug into that, they've come to conclusions. They're like, oh, like we're preaching dogma ourselves, and we need to
Right.
have some self-critiquing so that you can have a trusted source of saying, okay, when we say these things are true, that you can trust it, and then the literature references there, as well as open discussion about where there is still uncertainty about treatments that that there are studies that have contradictory sort of implications, and to just keep digging and to continue being just as transparent as we can be about the things that we believe to be true. And on the hormone testing side of it, it's a good or bad, depending on how you're describing it, example of how dogma can be so deeply entrenched. I mean, there's this topic that I've got my soapbox on, which is this whole idea of using hormone creams and gels. And okay, once you use those, some of them have proven to be effective and some of them are not. But then the step further of like, how then do we monitor them, where people have completely diametrically opposed positions, some which are fairly well defensible in the literature, and some which is just a bit of a house of cards. But it's been said for so long and with such confidence that it becomes really confusing to where like there's no shame in being confused on that topic, because the voices and the messages are varied in ways it's quite astounding, really.
Yeah, and that's what I appreciate about you guys in terms of trying to stick it with the science and not fall into the dogma. So even if it comes at, okay, this isn't the right time to do, or this isn't the right tool to use the Dutch test for,
Sure.
then that's important that you guys pointed out. Really appreciate that. So maybe we can go into the hormones and the testing itself. Estrogen is one of those hormones that anytime I put out something on estrogen, be it a minute long or something, I get, people agreeing, people completely disagreeing. It's one of those hormones that riles people up, really. And so maybe we can talk about that a little bit in terms of just, breaking up the types of treatments that we have. What's the best way to monitor? And, I'll let you kind of take it away from there.
Sure. Yeah, well, and I think it's important to start first with no HRT. Because even that can get confusing. And estrogen is the most difficult, because as you look at a hormone, let's just say profile, estrogen is always on the side of there's not very much of it. So just as an example, I came from the world of saliva testing for several years, doing lots of that. The amount of estrogen in your saliva is like 10,000 times less than cortisol. So cortisol is relatively easy to measure in saliva. Estradiol is very difficult. And so that just starting with, how do I even know that you are either hormone sufficient or hormone deficient, or maybe in a state of excess? And for that, we need the right tool. And that's where I ended up leaving the saliva model, and I should say, keeping saliva where it's strong, which is to tell a cortisol story. But when you start telling the estrogen story, this is where we get into dogma. And the dogma says, now hold on, for cortisol, the reason saliva is really good is because you're measuring free hormone, and that matters. And then you move over to estrogen and you say, why would the same rule not apply? Well, conceptually it may, but it's so difficult to measure in saliva that you'll even see, with due respect, saliva labs that are very good labs generally, where there's one in particular that comes to mind, where the postmenopausal range is actually higher than the premenopausal range. And you just slow down and stop and say, no, wait a minute. There's no way that's true in biology. Correct. What does that mean? Well, it means there's so much noise in the test that you're essentially just getting the same numbers for the hormone sufficient and the hormone deficient crowd. Whereas when you move over to our test or a really solid blood test, you find that the premenopausal women, on average, have 10 times more estrogen than the postmenopausal women. Now, that's a biological truth that you need the right tool in order to differentiate between, again, the sufficient from the deficient. So once we've come up with the right tool, and in that case, it would be either the Dutch test, which I think we've published data that says is a really solid way to do it, or two, a blood test. And in that's where methods matter. And you want to make sure you're using LCMS instead of your sort of cheaper standard assay, which works great for cortisol, but not so well for estradiol. So now we've got a solid value on, do you even need HRT? And then once that is true, then I'm a chemist. I'm not the right person to say what, I mean, I have my opinions, but what dose and what route of administration you ought to use. But, you know, patches, gels, creams, you know, different things can be used. So then you enter into this new question of, like, what tools should I use to monitor it? And, you know, for me, I think there are scenarios for which blood testing can work well to monitor HRT. I think testosterone, it's a pretty solid option. For estrogen, the variable is, does it go up and down quickly throughout the day? So for example, if I put a gel or a cream on, there's a pretty big bounce throughout the day. That's not great for blood testing, not because it's wrong, broken, whatever. It's just you're shooting at a moving target. And if you look at the published data on an individual level, it's not predictable. So, okay, that's not such a great idea. That's where the urine is a nice option to capture big chunks of time early and late in the day. And then that conceptually works really well. And so what we've done is then published our data to show that the Dutch test does a really nice job of differentiating between those not on hormones, those on a low dose of hormones, like a 0.025 patch or a gel cream equivalent, 0.05, 0.1, which is more hormone than I would choose to use. But again, I'm a chemist. I don't get to vote on what you give your patients. But the point is that the test can differentiate. So just as an example, I had a friend who used patches. She hated it. She said, man, when I use a patch, I feel, and she starts to describe something that sounds a lot like estrogen dominance. I'm like, well, that's odd. So I tested her. And what do you know? She goes from, so if you're normal, you're here. Then you hit postmenopause, you're here. And when she put a patch on, she was responding way more than the average person. So like, okay, I don't know why you're absorbing more estrogen, but this is a good tool to confirm what you've already concluded in how you feel. And now we can optimize your therapy, which means either A, lower the dose, or B, maybe for some reason a gel or a cream is going to work better for you. And so what we've done is tried to overlay the response of those products with the clinical data that's available that says, look, where do you need a woman to get in order to optimize bone mineral density, hot flashes, vaginal atrophy? Those would be the big three that women suffer from. And so we've got our sort of target range where we can sort of triangulate between dosing, clinical impact, and laboratory testing. And I think you can do that in a way that makes for a reasonable model. And when you start over and you try to build that model with saliva testing, which a lot of people do, you cannot do that. Like the data just doesn't align with the creams and the gels in particular. And that's a story you're probably familiar with, where when you put a hormone on your skin as a cream or gel, the saliva has this weird exaggerated response that half of our world has rejected and half of our world has strained so hard to make clinical sense out of. And I used to be there. I used to lecture and say, hey, this makes sense. And as I started to dig into the data just completely aligned with the opposite story. And so I have discarded that. But our world of functional medicine really struggles with, to be honest, just being honest about what the data says so that we can progress towards, best practices for those scenarios.
Yeah, you can sometimes get really fixated on your beliefs, I think. So if you believe wholeheartedly that saliva is the way to test, then it's very hard to convince yourself otherwise. And so that's certainly a challenge. And so,
I would say too, there's an origin story there that justifies the position before you scrutinize it. And that is, you go way back in time, people are taking progesterone creams and estrogen creams, and nobody separated estrogen and progesterone because their responses are different. So then what you get is with the progesterone cream, which you really shouldn't use because the evidence doesn't support it. But what you end up getting is you get no response in serum. And a lot of these women feel better. So then you have this conclusion that's confirmed by all these stories that says blood testing is wrong. And you see the saliva results moving. So you think there's got to be truth there. It's kind of that simple of a story. And so people chase that for 20 years. But as you pick those apart, treat the hormones separately, and really interrogate those conclusions, you realize there's no substance to that. And the truth is more nuanced. It's different per hormone. And you have to really work your way through those conclusions in order to end up somewhere where you have a reasonable position that the data is in alignment with.
Yeah. And so if I could stick to the place where we're at before hormone replacement therapy, so just monitoring as a baseline. You
Yeah,
mentioned a little bit about estrogen. Maybe progesterone would be also a good point to mention
sure.
about baseline. I think obviously saliva would be good baseline prior to progesterone therapy, correct?
Can be. So
Can.
there's an interesting study that just came out last year, like about a year ago. And what they did is they took commercially available
Mhm.
tests and they just looked at 10,000 results and just said, does this match the story that biology tells? And what they found is, as I've described with estrogen, it didn't work. Basically, the assays just didn't have the sensitivity, and the data just sort of falls apart. It doesn't work. Then they moved to progesterone. What they found was really interesting, is that when you look at the blood tests, the results match the biology story. You say,
Mhm.
okay, that's our bar. Like that's
Yeah.
what we're comparing to. And then they move to progesterone and they move to these research methods that are pretty sensitive, a little more expensive if you want to run them. And they found the data matched up pretty well. Then
Mhm.
they took one more step to what's more typically what's commercially available, which is cheaper, easier, and easier to automate. And what they found is it went from strong correlation to moderate correlation to now low correlation. So what the saliva story is that what is in your saliva is
Mhm.
absolutely a viable way to characterize your patient as it relates to progesterone.
Mhm.
But the test itself has to be sensitive enough and accurate enough. And that's where the question I would ask, which is what we've proven of our test, is simply does it correlate to a high quality serum assay throughout the month of
Mhm.
a group of women? And most people, just being honest, most people who do saliva testing use a test that has not been proven at that level. So the
Okay.
potential is there. It's not that hard, but you just have to choose very carefully. And so you want your lab to be high quality when it comes to that. So sorry for the long winded answer, but
No, no.
yes, progesterone and estrogen in saliva can tell the right story. I mean, even estrogen, if you go back to the older methods that are highly manual, very expensive, but very sensitive, the
Yeah.
serum correlation is actually pretty good. Then people move into these cheaper, easier to do, something that I would be more interested in using because you can use robots and it's easily automated.
Right.
But the data falls apart because you lose about 10x in terms of sensitivity. So it's, and all of that's not very interesting to doctors, right? It's nerdy chemistry
Right.
stuff. But at the end of the day, you want to use a test that's proven, and a lot of them that are on the market simply aren't.
Yeah, I think what's really valuable to us is to have that clinical, expertise based on the knowledge that you just mentioned. So if we know what you just said and have that deep understanding of it, then we can translate that into clinical practice, and that
Right.
is the best thing that we can do for our patients instead of that dogmatic approach of, oh, creams and gels and all the things that I've been taught is what I need to continue. So that's
Right.
progesterone. And then testosterone, maybe we could touch on testosterone prior to HRT as well.
Yep.
Obviously, blood seems to be the best one in LCMS
Yeah.
assay.
This is the big
Mhm.
area where we as urine testers have to be sort of open-handed about the fact that there's a weakness to urine testing that there's a long nerdy story there that we can tell, but it doesn't correlate to serum um, as much as well as estradiol and progesterone for reasons that have to do with biology and excretion and urine and that sort of thing.
Right.
But leaning into serum for testosterone, both with and without therapy, I
Mhm.
think is should be considered the gold standard. And the urine test, so the way we word it is that for estrogen and progesterone, the Dutch test is a really nice primary, like first like attack.
Mhm.
You can use it by itself.
Yeah.
But with testosterone, it becomes more of a complementary product of hanging your hat on a serum test and
Yeah.
then using Dutch to see how is it metabolized, how does it turn into estrogen, how is the estrogen
Mhm.
metabolized. Really powerful tool. But if you're using it in isolation, you're going to have some issues, and that's where we again just have to be
Mhm.
honest about the limitations. The other nice thing about Dutch is that particularly for men, if you're
Mhm.
trying to solve the testosterone issue and you have no window into the stress response and the HPA axis,
Right.
it's going to be really difficult because there's a lot of overlap between a stressed out, anxious guy and a
Mhm.
low T guy, right?
Absolutely.
And so that's where what I mean. It becomes a really nice complementary product, but again, you don't want to use it by
Mhm.
itself in isolation for testosterone.
Mhm. Okay. And just sticking with testosterone, I did want to ask you a couple of follow-ups. One was about how you see urine testin being superior in the certain genetic SNPs that occur as it pertains to testosterone. I know Dr. Saltiel has spoken about this. Is something that you know would be helpful for the audience to know, if that's something you can expound on.
So the issue there is highlighted in people from Southeast Asia, and that
Mhm.
is this, that we don't test for estrogen or testosterone. We don't test those hormones in the urine. We test their water-soluble conjugates. So
Yeah.
you go testosterone, your body says, I can't get rid of this in a water-soluble form unless I add a glucuronide or a sulfate form. So now it's got a little sugar moiety or something like that on it. Now, only the bioavailable
Mhm.
free fraction is free for that conjugation. So in that sense, conceptually, what's in your urine is a nice reflection of what's bioavailable,
Mhm.
but it is dependent upon the proper conjugation process.
Correct.
And for testosterone, there's a specific enzyme that conjugates testosterone and a couple of its metabolites. But if you
Mhm.
go any further away from testosterone, estrogen, even a lot of the other testosterone metabolites, it's a different enzyme that conjugates it so that it can be in urine. And it just so happens that that enzyme for testosterone
Mhm.
conjugation, there's a genetic variant that renders it ineffective. Now, when you start saying like genetic variant, you think of like clinical things
Mhm.
going on. There's not really a strong association with
Right.
anything clinically dysfunctional about this. It just means testosterone has to find a different way to get excreted
Mhm.
into the urine. So what you end up with is so this variant is very prevalent in Southeast Asia.
Yeah.
So if you compare 20 men from China or women and 20
Mhm.
men from Caucasian men from wherever, you're going to find that there's a serum correlation that's pretty strong in the non Southeast Asian group,
Mhm.
and that in the Southeast Asian group, you're going to find serum not correlating, and it's sort of urine's fault. Like the
Mhm.
urine is
Yeah.
underrepresenting what's going on, and that genetic variant is like prevalent like 2/3 of people
Mhm.
from China, as an example, but also obviously, as you spread out from the globe, I don't know where that stops exactly,
Right.
but in, for example, the Caucasian population, it's only like 2%, right?
Mhm.
So for
Okay.
us, we have looked at that really carefully, and so we can find patterns in your urine to say it's likely that your urine is probably a false
Mhm.
negative in terms of what's going on with your testosterone. What's the suggestion then?
Mhm.
Go do a blood test. So that's and how that relates to genetic testing, I wouldn't consider myself an expert. It's
Right. Mhm.
UGT2B17. That's the
Yeah.
enzyme. Um, and it's just a weakness of urine testing that we have to compensate for by the other things that we measure
Mhm.
and by complementing what we do with a serum testosterone test and put the two together to get,
Mhm.
really optimal understanding of what's going on with testosterone.
Yeah. And the other thing I want to ask you about testosterone is this interesting interplay between testing testosterone in men and how that's recommended by all the major medical societies,
Right.
and then when it comes to women, where ACOG and NAMS by and large recommend against testing. And so I want to just maybe have your thoughts on that about the clinical validity of testing
Right.
testosterone in women and how that correlates to symptoms.
Yeah, when we went through our HRT course, which we're just now like editing and that sort of thing,
Mhm.
we had this sort of idea of like concentric circles of knowledge of starting with simple stuff and
Yeah,
then building out to the more complex. And when we got to simple, we included testosterone therapy. And then
yeah,
as we dug into it, we went, you know what, this is
yeah,
really important, but
right,
it's by no means simple.
right.
And the reason for that, I think, is because there's so much endocrinology going on, meaning
Mhm.
intracellular stuff that happens. For example, DHT is a good example of how you can explain this. If you think about DHT, it's a metabolite of
Mhm.
testosterone. It's 3 times as potent. So if
Yeah,
you get DHT in the cell and it hits those androgen receptors, it's very potent. That's why if you're a woman and you make DHT, you're going to get hair where you don't want it, acne, losing your hair, that sort of thing. But when you look at the science of it,
mhm.
measuring DHT is actually not the best way to
Mhm.
measure DHT. What happens is testosterone goes into the cell. In
Mhm.
that cell, it turns into DHT. Now it's really potent. It hits the androgen receptor, and then in that same cell, it gets turned into androstenediol, which is one of the metabolites we have on our panel. So that thing itself is not androgenic, but it is a representation of intracellular DHT production.
Right.
And so so what's going on at the receptor level with testosterone and its metabolites is not simple. So just measuring testosterone that happens to be cruising around in your veins, in your blood, or even DHT is not the whole picture. It's really complex. So there are a number of studies that I've read that have broken this down in certain populations. I just read one yesterday where they were looking at kids, and what they found is free testosterone in blood correlated with these non-testosterone metabolites in urine, because they represent essentially the reservoir of substrate that you can make testosterone from intracellularly. And it's just a complex story. So all that to say, they have not directly linked a particular testosterone measurement with clinical outcomes in a meaningful way to where it can be a paint by numbers scenario like it is with men. If your testosterone is below a certain point, it means something. But in women, it's testosterone, it's the precursors, it's how much do you make DHT. So there's this three-dimensional story going on. And when you look at a Dutch test, especially in conjunction with serum, you get a story, but it's not simple. And I think what a group like that you mentioned, I think it was the North American Menopause Society, but those types of groups are really trying to create paint by numbers stories for people that they can follow. And that's really good because it simplifies it and you can draw conclusions from the numbers that you have. That story is just not that simple. So we feel like if you look at the breadth of what we offer with a serum testosterone, with SHBG, and you put this whole story together, you can really characterize a woman well as it relates to those hormones. But it's never going to be a simple, if this is below this, here's your treatment option. It's just more complex than that.
Yeah, I appreciate that. I want to spend the rest of the time we have maybe talking about the HRT and monitoring that we were going to come to. So maybe we could take each hormone or however you want to do it, and we could maybe do estrogen first and just talk a little bit about being on estrogen therapy and how that correlates to monitoring.
Yeah, it might make for a simpler conversation to start with progesterone, because that's one where us as a lab industry, we have to just sort of be honest and tip our hand and say, we don't have a lot to offer. Because as it relates to, your primary reason that you're using progesterone is to counter the effects of estrogen. Where is that most important? In the endometrium. So if you narrow the question and you say, what does lab testing have to inform what's going on in the endometrium with either oral or vaginal, which are the two proven ways to take progesterone? And the answer is nothing. There really isn't a lot of value in lab testing for progesterone. And that's just something we have to be honest about. Probably the easiest one to explain would be vaginal progesterone. If you put progesterone in the top third of the vagina, the literature says it works really well. Why? Because there's a special blood flow from the top third of the vagina into the uterus. And the uterus gets 10 times more progesterone than what's in circulation. So then you ask yourself, okay, what lab test speaks for that? And the answer is nothing. When you take oral progesterone, it's a more complex story, but the end of it is, as it relates to the endometrium, there's not a lot of feedback. So what you lean on is not the labs, you lean on the studies. The studies say 100 milligrams, 200 milligrams is effective for either oral or vaginal. And we know that the studies say also that transdermal is not effective. It's not consistent at protecting the endometrium. We take those truths, we apply them in practice. The lab testing might add some informative value, but it's weak, and it's not what you should hang your hat on in terms of the dosing that's going to be effective. So that's the progesterone story, is that the labs don't really win. So that's, for us, just good to know, inform people, and off you go. When it comes to estrogen, it's a bit of a different story. Did you want to?
I want to ask you a quick follow up on the progesterone, which is, and maybe we touched on this earlier, but how oral progesterone, because I have the patients on oral progesterone, and when we do serum testing, I'm wondering if you've been able to identify serum level, or there are studies out there that have been able to identify serum levels and how they correlate to kind of the uterus and uterine progesterone levels. To your point, they probably haven't. As you mentioned, the same as with urine testing. But I'm curious because I have these women that are on progesterone. They clinically feel great, but we barely get movement in the serum as well. So
Right. So this is an area where testing can be more detrimental than not testing, because the message that you give does not reflect what's going on. And so two different pictures here. One is if you're using a mass spec assay that's accurate, and the other is if you're using the more standardized assay. Either way, you should not get numbers that you can rely on. But here's what happens. You take it when? Bedtime, right? So you take it at bedtime, it peaks 1 to 2 hours later. So your patient takes it at, let's say, 10 while she sleeps. At midnight, she gets a peak. By 2 a.m., it's back to baseline.
Right.
And now you wait till 6 a.m. and you get up and you get into the lab at 8:30 and you get a draw. Or you do a saliva test at waking. Either way, you've missed all that action. You know, I always tell people it's like spending 10 years, spending all of your days studying the activity of bats. It's like, oh, I'm an expert now. I know everything there is to know about bats. Like, no, you don't. Everything that's interesting that happens about bats happens while you're sleeping. So no matter how much of an inquiry you ask, you're never going to find the right answer. So, but there's and this gets into, again, the nerdy chemistry, but part of what's confusing about that is if you go to the point where it's back at baseline, so it's about 1 a.m., okay? If you look at a mass spec assay, so that's LCMS, that's where you're going to find. But if you do a standard assay that's cheaper, that normally is very accurate, because of all those progesterone metabolites you've just made in your gut, they artificially bloat that number. So you'll raise it up to like 10, 12, 15 in blood, but it's not real.
Right.
It's not real. And so then in the morning, what you catch is you catch the tail end of that artificially elevated number. You don't want to chase that number, because we know with oral progesterone, you get impact from progesterone itself, but you also create a lot of metabolites that still have progestogenic, that's the right word, effects. And so it's this milieu of progesterone impact. We know from the studies that it works, but lab values are not going to tell you if and when it works. And what's dangerous about it is, I went to a lecture a long time ago, and this guy got up, well-known guy, like pretty arrogant tone, and just said, look, if you're premenopausal and you get a 20, that's good. So I'm going to give you oral progesterone till I hit a 20 in the morning. And as if that, like, there's an equivalence there, and there isn't. And it was what the funny thing was, is I heard him saying that, and then during the break, I heard him saying, honestly, I'm frustrated because I used to get those values regularly with high dose progesterone, and lately they've all been low. And I wasn't in the conversation, but my thought was your lab probably switched from a standard assay to an LCMS assay. So what you were measuring is this artificial number that's not even real. And when it went away, nothing was actually different about your patients. It's just better lab testing. But the truth of the matter is, a serum test does not match up with oral progesterone in a way that makes it useful. And again, it's more likely that you'll be misled than that you will be helped. So again, I would discard the lab testing in that situation, lean on the studies that say, depending on your estrogen dose, 100 to 200 milligrams works just fine, and move on.
Okay, good to know. Yeah, we could definitely talk about estrogen and its monitoring as well now.
Sure. So with estrogen, I mean, we could get into the details, and we sort of already have, but I would just do away with the saliva testing. It's not a great way to get a baseline. So then I'm going to ask the question, how are you taking it? So if you're taking it orally, which we don't recommend, but one of the things that we've discovered in creating our hormone education is the fears of oral are a little bit exaggerated or tend to be in the integrated space. Topical, transdermal, I think is always better, but the risk with oral, it's just slightly more risky for reasons we don't need to get into, and which you're familiar with. But if you use it orally, or a patient's on oral, you can't use a urine test. It's going to go into your mouth, into your gut. You just get a gobs of these metabolites that do not reflect systemic levels. Not a good test. And for that, you'd need serum testing to monitor it. And even that is going to move pretty fast to where the testing is of moderate value at best. Now, most of the people that you work with, that I work with, aren't using oral. They're using what? Either patches, gels, or creams. So we know creams are not proven. I'm not saying they don't work at all, but there are no clinical studies that say what dose of what product actually works. And that's where I think the labs can be a little bit helpful. But when you're using patches, gels, and creams, to me, the urine monitoring is optimal, because there's a response that's proportionate to the clinical response that we see from the studies that have been done. I mean, that's the nice thing about FDA approval, is those products have been tested for bone mineral density increase, for
Right.
vaginal atrophy, and all of that. And what we know is when you move to gels and you get to doses around 0.25 and below, they start to fail clinically.
Right.
And meaning they don't work for vaginal atrophy. You don't increase bone mineral density, and the hot flashes get better, but just barely beating out placebo. So that's that low sort of estrogen therapy range. And when we look at those particular products in urine, we're just up and out of the postmenopausal range. So that's where we say that's the sort of the minimal place you want to find people to see clinical impact. And then as you move up towards the luteal range and you get into the early part of the luteal range, now you're talking about doses that work very impactfully for bone, for vaginal atrophy, for hot flashes. So that's kind of the sweet spot that we shoot for, that we feel like there's evidence for patches, gels, and also creams. Now, you can use serum testing for that. And what the data would suggest in serum is that when you move into that range of about 20 to 60 picograms per milliliter, that it correlates with clinical outcome. The Archer study is a really nice study where they used doses that worked, they used doses that didn't work, and you can see that the serum's got to be up around 20 to 60. But the problem is, again, any particular one individual at any one particular time is going to be moving a lot throughout the day, and you don't know if you're at a peak, if you're at a trough. There's a really nice study by Jarvinen where they actually published individual profiles, and you can see like one particular woman is higher than the target range, then lower than the target range, then higher than the target range, and also within the target range. So when you ask yourself, which of those values would you want to pay money for and change her therapy, you'd say, I don't really want to. And that's where, to me, there's justification in groups like NAMS that say, why even bother? But what they haven't considered is a test that integrates those values over time by capturing over large periods of time. And the only way you can do that is a urine-based assay. And that's why we were so interested in publishing our own data on those products, which we've done recently in menopause in I think the November edition that just came out, of showing how those therapies are responding in urine, and I think creates a nice model for testing patches, gels, and creams.
Excellent. I think testosterone we already mentioned, so unless there's anything else to add, I don't know if you wanted to
I mean, the only thing I would add about testosterone is that when you look at serum, you have what we want for any of these scenarios, which is interventional studies, where they've said these men are low, we give them a particular dose until they get into this range, and guess what? We get clinical impact that we expect to see, and you can close the loop on testosterone in single studies, and that's really powerful, and that's not available in a lot of these scenarios because the research just hasn't been done with a lot of them. So to me, I think the conclusion that testosterone makes the most sense. There are limitations. I mean, serum makes the most sense for testosterone, but there are limitations. It can move a little bit throughout the day, not as dramatic as estrogen. And that's only part of the story. How much estrogen are you making? How's the estrogen getting metabolized? How much DHT are you making? Some of those stories are better told by a urine test, but the serum story can be defended well in the literature.
Okay. And maybe as a last question, I just want to ask you about the estrogen metabolites, because that's not an area that we touched upon. Just as to if you can comment on, because metabolites is obviously something that we get in the Dutch test that we don't get in serum.
Right.
And so if you can speak to the benefit of the metabolites and their clinical validity, maybe a little bit, and then we can wrap up.
That usually is where the urine test begins for HRT. Is most people historically have said, well, either they're using saliva, which I think is misguided, or they're using serum, which I think is difficult, or they're using nothing. They're not using any test to gauge the dose. And so my point is, I think you can use the urine to tell yourself if you got the dose right. Okay, that's question number one. Then the second question, which urine, as you're alluding to, can open up a window to, is what's my body doing with that estrogen? So there's phase one metabolism, where I've got three different doors the estrogen can kind of flow into. Either the 2-hydroxy, which has more friendly properties as it relates to cancers that are related to estrogen, or the 4-hydroxy, which some people call it the good, the bad, and the ugly. The 4-hydroxy can damage DNA. There's potentially carcinogenic risk that is at play with that particular metabolite when it predominates. And then there's the 16-hydroxyestrogen. The 16-hydroxy can kind of cut in both directions in that it creates more estrogenic impact. So sometimes it's good that you make some of that if you have very low estrogen, because it's it may help your bones. It may help like the estrogenic impact. And then if if you're favoring that strong estrogen and you have a lot of estrogen on board, it can exacerbate like high estrogen symptoms, estrogen dominance, that sort of thing. So we want to evaluate, am I pushing down this pathway or these other pathways? And, one picture is a little bit more favorable. And then we know that there are nutraceutical interventions that you can use, like diindolylmethane, indole 3-carbinol, to help push it down what's considered that more favorable pathway. That's phase 1. Then phase 2 includes methylation. And methylation is a protective step to take the 4-hydroxyestrogen and the 2-hydroxy to an inert form that you can then get rid of. And so all we're looking at there is, what's your conversion? When you make a hydroxy, are you turning a methoxyestrogen, turning it into that inert end product? So me, for example, I have a COMT, the enzyme that does that, mine's defective. So every time I do a Dutch test, I make the 2-hydroxy. I don't turn it very well into the 2-methoxy, which means for me, I could use support in that area, magnesium, things to support methylation. Why? Well, because as a guy, those 4-hydroxyestrogens are also relevant as it relates to prostate cancer risk. And so for both men and women, we want to evaluate, what's my estrogen level? How is it being metabolized in terms of phase 1, sort of good, bad, ugly? That's a little of an oversimplification, but that's the idea. And then, am I making the safe inert end products out of these reactive intermediaries or not? So those are like the 3 levels of questions that we get to ask about estrogen, which brings value to the testing that we're doing.
Yeah, well, I appreciate all of that. And so we can certainly wrap up here. I really appreciate your time again and all your expertise. All the education that you guys provide is hugely beneficial for clinicians like me who are trying to, turn the tide that's out there and actually get good data and good clinical outcomes with our patients that are really suffering so much. And hormone replacement therapy can be such a powerful tool for them. So I appreciate you again. Thank you very much for your time.
Yes, thanks for having me. It was a fun conversation.
Absolutely.